Good afternoon. Thank you for joining us. Hi, I'm Dr. Jim McDonald, Commissioner of the New York State Department of Health, and welcome to Commissioner's Grand Rounds. Glad to have you with us today. Unraveling long COVID, current trends and expert perspectives. I am thrilled about today's Grand Rounds. I really want to thank the team for putting this together. There's been a lot of preparation just to get us where we are today. And I want to go through a couple little the administrative slides really quickly here, but I'm thrilled about the topic. If there's something we need to know more about, I don't know what it is. Long COVID is something we really need to do more and more about. You know, the pandemic, it's impacted us all. The population trauma, I think we're still unpacking that. But when I just think about how many people's lives have been permanently changed forever from acquiring a viral infection, it really is quite different, quite disturbing, quite concerning. And it's one of those things where I look forward to what we can learn as a discipline and as a noble profession to see how we can actually help people. Every disease, I hope will get curable. This is one I hope as well. And as we go on to our slide, I want to go to our next little thoughts here really quickly here. Just one of those little grand rounds, little just disclaimers here is if you have questions, go ahead and email us. Our email address is grandrounds@health.ny.gov. That's grandrounds@health.ny.gov. We will not get to every question. Going to open with that because we have a wonderful panel today. We have a lot of questions to ask our patient. We're going to go through with our patient first and with our panel. But as we get through with things here, if we have time for questions at the end, we will. And I'm getting your questions in real time, so if I can weave them in to our conversation, I'll do that as well. The next slide I want to show you is about to obtain continuing education credits. And I'm going to ask you right now to get your phone ready. I've got mine ready. There's going to be a one question poll coming up in just a minute. So let's get that phone out, get your camera app open. But if you want to attain continuing education credits, and I do, you got to stay for the entire session. Where else would you go? We're going to have a post-test link that'll be shared. Please do that as well. And please to use the same email address you registered with. And keep in mind, accreditation is only available for the live session. And the recording will be posted after the session, but will not offer any credit. And I want to thank the medical side of the state of New York for crediting our Grand Rounds. And if you take the whole session, you get 1 credit of AMA Category 1 CME. So I think that'll be great. Now, the next slide, I told you to get your camera ready if you do not mind. Oh, wait, got some disclosures here. I'm going to let you read the disclosures on your own there. But when it comes time for the next slide, which is going to be you to do that one question poll here. Thank you, Mike. If you just take your phone out right now, like I'm going to do right now, just want you to grab onto that. And if you put your phone close enough, you get a little hyperlink at the bottom. Then you got your question you can answer. And then it just tells you what is your current role. I'm picking physician because that's what I do here, hitting submit. And look at that. I completed the survey. No harm done. That was great. All right. Good for us. Now, next time we show you a slide, it'll actually be the slide at the end where you can actually scan again to get the post test. So we aren't going to give you that just yet. So why don't we get now into our conversation for just a minute here. I'm going to first introduce our first speaker, which is Julie. Julie's a patient who suffers from long COVID. And Julie, first thing I want to do is say thank you so much for being here today and sharing your story. You know, one of the things I've talked to Julie a little bit about in the past is that, you know, as physicians and healthcare providers, we often learn from our patients. And I think there's something very wonderful about Julie participating with us today and just helping us out and just understanding what is going on with her story. So Julie, first question I want to ask you is, can you describe some of the symptoms you experienced with long COVID and how they affected your daily life?
Hi, good afternoon, everyone. And yeah, thank you. That's definitely on the front burner, right? I had to write them down because there's a lot of them, and brain fog is one of them. So memory. But yes, I've experienced very extreme fatigue, brain fog, and working memory issues, cognitive impairment, post-exertional malaise, intermittent tachycardia, heat intolerance, and general difficulty regulating body temperature. And unsurprisingly, on top of all of that, a lot of anxiety.
Yeah, Julie, thanks for sharing that. And that's a lot. Are you still experiencing all those symptoms even to this day?
Uh, the heat makes them all worse. So because the temperature finally dropped, certain things like the intermittent tachycardia are not very present, which is wonderful. Um, but other ones like the brain fog and post-exertional malaise and heat intolerance are definitely very much there.
So let me just go on to our next question, and thanks for sharing what you shared just then. What kind of support or resources, if any, have been helpful to you as you've managed your symptoms over time?
I got very lucky that I was able to get into the Mount Sinai's new long COVID clinic and being able to have a continuity of care with one physician instead of hopping around to multiple specialists with the sort of shrug fingers crossed approach to what to attempt to do has been really helpful. So instead of seeing a cardiologist and a rheumatologist and neurologist, etc., I get to just see one person who checks in with me and who I can check in with as well. And that has been pretty game changing.
So, I mean, that sounds wonderful, and I can understand kind of what you're saying there too. Like when you have to go see multiple different people with various levels of understanding of this, that doesn't exactly inspire confidence because we're still learning about this new disease here. So, have you noticed any particular activities, Julie, treatments or lifestyle changes that have made a difference in managing your symptoms?
Uh, I mean, unfortunately, not really. Time helps a lot. The longer I can go in between having COVID, um, the longer periods of time not having it help to alleviate a lot of the ongoing issues. But I am an overachiever and I've gotten COVID 5 times already. So it's kind of hard to not get it when you're immunocompromised. But time helps, and then certain things like experimenting with different kinds of um, treatments for other things like POTS or um, MS, like having various ways to manage fatigue and exercise and things like that have helped a little bit as well.
Yeah, thanks, Julie. And do you want to tell us when did you originally get COVID? Like, how long has this journey been for you, my friend?
Oh, since the beginning. I think I got it first April 2020.
And so, we're now here in 24. So, have you really been struggling with this for really 4 years?
I first noticed the long COVID symptoms in about April of 2021.
Wow. So it's really been quite a journey for you now, 3.5 years into this, and it's still, do you still have hope that you'll get a full recovery? Where are you with that, my friend?
Um, I don't see why not. Um, I I feel like it's really hard, but I'm always going to leave room for the possibility for there to be just as much good mixed in with the difficult. So, um, I am cautiously optimistic, but I think because it is so new, but thankfully so many people are taking it so seriously, um, why not?
Yeah, why not? I love that. Why not? That shows some resilience and perseverance on your part. So, Julie, just one more question for you. What do you wish others understood about living with long COVID, particularly healthcare providers, because that's our audience today?
Absolutely. I think I feel like it's the same way I feel about a lot of other um, chronic health issues because I also have Crohn's disease as well, and I have for a very long time. So any kind of invisible disability and the medical trauma that goes along with it, just being taken seriously goes such a long way. Being believed, having things spelled out in a way that is understandable, uh, while not sugarcoating it as well. Um, and then really just understanding what's actually happening. Like, I know that my autonomic nervous system is ooh, there's a truck, sorry, um, is what's causing a lot of these issues. But I I work in a library, so I'm really good at looking up peer-reviewed journal articles where a lot of other people may not be. So having access to trustworthy information is also very helpful. Though I understand a lot of this is so new that it can be hard to know where to get that. Um, but yeah, I think just being equipped with as much information and support as possible uh, has really helped to get me to this point.
Yeah, thank you, Julie. I really appreciate you sharing all that. One of the things you just said, and there's a lot of what you said was memorable, you just used the phrase invisible disability. And I don't think I've ever heard anyone use that before. And I think that's a powerful collection of two words there together. And I also heard you highlight the point of just being believed. And I think that's one of those things where those are two important pearls for us as healthcare providers to take home with, and there are more coming. So thank you, Julie. I want to now introduce our panel. I'm really glad to have our panel with us today. It was great to have our patient, Julie. So first, I want to introduce Dr. Micheal Peluso, who's an assistant professor of medicine in the Division of HIV, Infectious Diseases, and Global Medicine at Zuckerberg San Francisco General Hospital, University of California, San Francisco. Dr. Peluso and I chatted earlier about my time at UCSF many years ago. Also want to introduce Dr. Alba Azola, who's an assistant professor in the Chronic Fatigue Syndrome and Related Disorders Program and the director of the Long COVID Chronic Fatigue Syndrome Clinic. She also serves as co-director of the Clinical and Translational Research Core within the Johns Hopkins Brain Health Program in the Department of Physical Medicine and Rehabilitation at Johns Hopkins University of Medicine. So welcome, Dr. Azola. And I'm really thrilled to have also Dr. Juan Pablo Wisnivesky, who is a professor in cancer prevention and control, environmental medicine, and climate science at the Icahn School of Medicine at Mount Sinai. He's also affiliated with the Graduate School of Biomedical Sciences and the Institute for Climate Change, Environmental Health, and Exposomics. And then also want to introduce Dr. David Putrino, who's the Director of Rehabilitation Innovation at the Mount Sinai Health System. And also thrilled to have Dr. Geetika Sood and Dr. Amanda Lanz, who's going to join us for the question and answer session following the panel discussion to provide additional insights. Dr. Sood is the Medical Director of the Bureau of Healthcare Associated Infections at the New York State Department of Health. She's also an assistant professor and associate hospital epidemiologist, as well as an infectious disease physician at the Johns Hopkins University. And Dr. Amanda Lanz serves as the medical epidemiologist at the New York City Department of Health and Mental Hygiene. So great to have everybody with us today. Really wonderful panel. Ken, thank you for joining us. Let's dive in. Question and answer time, my friends. We're just going to dive right into this and see where this brings us. So the first question really is for Dr. Peluso and Dr. Putrino. I'll start with you, Dr. Peluso, if you don't mind. Can you tell us a little bit about the kinds of symptoms patients with long COVID are presenting with in your experience? Dr. Peluso, to you, please.
Yeah, thanks so much for having me. So, what I like to tell people is that there's not a single long COVID syndrome. There's not really a single set of experiences that everyone has. But I think that what Julie described is really sort of classic for what we see in a majority of patients with long COVID. So at least in San Francisco, by far the most common symptoms that we see are fatigue that in many cases can be really quite debilitating and really interfere with people's lives, as well as the other symptom that she mentioned, which is sort of cognitive symptoms, or what's often described as brain fog. I think often that term to the outside world kind of undersells what people experience. It can be really, really debilitating, and people who were once able to sort of do their job with ease are unable to do so as effectively or as efficiently as before. And some of the most striking cases that we've seen have actually been people who have lost their jobs or had to take sort of major accommodations because they're not able to kind of function on the same physical or cognitive level as before. I think the other points I would make are that, the symptoms can differ a lot between people. And sometimes we talk about, that heterogeneity as being a challenge for sort of the research and the clinical care. But I don't really think we should use that as an excuse. I mean, that is the condition. And so it's incumbent on us trying to understand it and trying to treat patients to figure out a way to navigate and manage that. And then I think the other point I would make is that the symptoms can also sort of vary over time within a person. So, sometimes people have a good day or a good week or a good month, and then they have a setback that can go on for days or weeks or months. And so there's both variability between patients and also variability over time within a patient that can sometimes be quite unpredictable. Almost always, this has an impact on people's quality of life, and I think that that's what really matters and what we really want to try to fix.
Yeah, thank you,
I'll
Dr.
David.
Peluso. Let me go to Dr. Putrino. Dr. Putrino, you just want to, can you add some wisdom to that as well? Dr. Peluso did a great job, but what are some other thoughts you've seen in your own clinical practice, Dr. Putrino, on that?
Yeah, I totally agree. Mike did a great job there. A few things that I would add. First and foremost, I think one of the really common symptoms that we often see that I really want to stress is behaviorally distinct from fatigue is post-exertional malaise. This is something that that folks with myalgic encephalomyelitis, which is sometimes called chronic fatigue syndrome, have been telling us about for decades. And it sort of represents this idea that if you exert yourself either physically, cognitively, emotionally, beyond a certain threshold, you will then pay for it with worsening symptoms and sometimes even new symptoms for days, if not weeks afterwards. This can be one of the most debilitating symptoms that people with long COVID experience, and we certainly see, at least in most studies, at least 70% of people with long COVID will experience post-exertional malaise as a symptom. And so I really think that that's important to point out. While we're talking about symptoms, I also think that it's important to note that many of these symptoms rely upon us to listen to the patients who are coming into our clinic and hear about it, their experiences. We need to be really careful about how we measure these symptoms. It's not enough to say, oh, you're fatigued, I'm just going to write down you're fatigued. We want to measure how fatigued they are. We want to use gold standard validated scales such as a fatigue severity score to understand how fatigued they are so we can monitor changes in symptom presentation. And I also want to point out that as we do that, it allows us to really build a picture of what people are experiencing with long COVID, because what is happening far too often is we're hearing from long-term disability and Social Security Administration, and we're hearing patients being denied benefits because we don't have some sort of objective record of their symptoms, even though the CDC states very clearly that a diagnosis of long COVID can occur without a test because we don't have a blood test for long COVID as yet. This is still leading to people having their benefits denied. So that's a really important point for action that I think needs to be stated over and over again, is our patients don't need to prove their symptoms to us. They just need to report them, and we need to be listening and receptive.
And Dr. Putrino, did you say there was an objective measure of fatigue? Like, is there some tool that you referenced? Did I hear that?
Yes. So, and we have a series of patient-reported outcomes that we use for each symptom, as well as objective outcomes that we use. But the fatigue severity scale was the one that I mentioned there. That's one of the outcome measures we use when someone tells us they feel fatigued. We want to know, the next question is, how fatigued are you? And so we use the FSS to measure exactly how fatigued they are at any one point.
Okay, so the fatigue outcome severity score, got it. So let me bring Dr. Azola into the conversation. Welcome, Dr. Azola. So Dr. Azola, we have, when we think about post-exertional malaise as a predominant feature in patients with long COVID, can you share your experience with this? I saw you nodding as others were talking. What have you been seeing with this?
So, as many physicians, I'm a physiatrist, and I've never heard of post-exertional malaise before the pandemic. And it's not a term that we're familiar with. And it's poorly descriptive, right? Post-exertional malaise, it sounds kind of nebulous, but this is truly a a significant symptom that needs to be understood so that we can explore it with our patients, because it's going to make a big difference on how we approach the rehabilitation and how we approach management of the patient. So post-exertional malaise is an exaggerated response to activity that was well tolerated prior to becoming ill. So this could be folding their clothes. This could be walking to the store. This could be running a marathon, right? There's different degrees. But what happens is that there is tolerance while you're doing the activity, typically. Like they're not feeling bad, but there's a delay. It could be hours. It could be 48, 72 hours delay, but then there's an exacerbation of symptoms, and they range from debilitating fatigue to body aches to migraines to tinnitus to nausea, sore throat. I mean, the list is very extensive. So these symptoms are quite debilitating and often require patients to stay supine in bed for sometimes days to recover. And what I wanted to describe about this, and something important clinically, is that the patient enters a push-crash cycle. I call it the Corona coaster, right? So these patients come in trying to, kind of push through and continue to work, encountering the crashes, and then as soon as they climb out of it, do it all over again. And as a physician that started seeing patients very early, like April 2020 in a post-COVID clinic, I saw patients significantly lose their function because of continuing to be in the push-crash cycle. So it is very important to identify those patients with long COVID that have post-exertional malaise, because it requires a different approach.
Yeah, Dr. Azola, I think that's the first time I've heard the phrase Corona coaster, but it kind of makes sense, doesn't it? And that push crash cycle, I think it really puts something in my mind I can remember here. I want to bring some other concept into our conversation. Or like, we learned very little in medical school about postural orthostatic tachycardia syndrome, or POTS disease, and dysautonomia in medical school. And we're learning that it is much more complex syndrome than just orthostatic hypertension. Can you teach us a little more about this, please, Dr. Azola?
Yeah, so postural orthostatic tachycardia syndrome is one of the types of autonomic dysfunction within the big umbrella of autonomic dysfunction. And early on, actually my personal experience, we had a POTS clinic. So I could see patients that present with this brisk jump on tachycardia, right? From just going to sitting to standing, and accompanied also by symptoms of orthostatic intolerance. So that means, brain fog, palpitations, sometimes sweating, flushing. So it's not only the jump on the heartbeat. In adults, it's about 30 beats per minute. In children, 40 beats per minute. But it's also this orthostatic intolerance symptoms. Now, an important point I wanted to make is that even though POTS is kind of the most commonly known and heard about, there's a number of other autonomic dysfunction syndromes that also result in orthostatic intolerance, right? So we can have a patient that actually has drops in blood pressures, like neurally mediated hypotension, or we can have patients that actually have persistent orthostatic intolerance without changes in blood pressure and heart rate. And there are studies showing patients with ME/CFS, or myalgic encephalomyelitis chronic fatigue syndrome, as well as long COVID patients, that show decreased cerebral blood flow while they're upright without a change in blood pressure and heart rate. So I just wanted to kind of broaden that concept of the point of orthostatic intolerance beyond the changes in heart rate and blood pressure.
Yeah, thank you, Dr. Azola. Dr. Peluso, let me bring you back into the conversation here. Can you tell us about other signs and symptoms that are discussed, such as brain fog or increased risk of clotting disorders? I know you talked a little bit about that earlier, but when does hit increased risk of clotting disorders? Are there patterns to these signs and symptoms?
Yeah, I think we're only really at the beginning of understanding these issues with potential clotting disorders post-COVID. We know that COVID is a highly inflammatory condition, and certainly during the acute phase of COVID, people are at higher risk of things like blood clots. The risk over the longer term is less well understood. I think that one of the most interesting observations that's been made, and this is kind of getting into sort of the more technical biological side of things, is that the SARS-CoV-2 virus actually interacts with a lot of proteins in our bodies that regulate the clotting cascade. So for example, proteins like fibrinogen. And there have been some really interesting and provocative publications over the last year kind of showing on a molecular level how this works. Why I think that this is important is beyond, blood clots that can cause things like strokes or pulmonary embolisms. These clotting proteins also help to regulate the immune system, help to regulate inflammation. And that can have downstream effects related to things like some of the symptoms that we see in long COVID, like cognitive dysfunction. So there have been some really nice studies that show that alterations in the ability of fibrinogen and fibrin to regulate neuroinflammation, for example, may contribute to symptoms of brain fog that are then experienced as inability to concentrate, inability to carry out complex sort of executive function, challenges finding words and things like that. Potentially they can contribute to physical symptoms too, although I don't think it's really fully understood yet. So this is one area of kind of major investigation that I think we'll see more coming out over the next year.
Yeah, thanks, Dr. Peluso. Dr. Putrino, I wanted to see if there's anything you wanted to add to that. It's funny, I was thinking about when COVID first started, it was the inflammation that really drove the morbidity and mortality, really before we had really what to do with therapeutics. But Dr. Putrino, I thought I saw you nodding during all that and a great deal of vigorous agreement there. Was there something else you wanted to add to that?
I think Mike's done a really great job of synthesizing the data. I think one of the things that we really need to keep pointing out is that that non-severe acute infection can still cause all of these things to occur. So there's no real correlation to speak of that we've seen between how severely ill somebody gets and their risk of starting to develop some of these sequelae, and where really the literature really is starting to show over and over again a few things consistently, which is that an acute SARS-CoV-2 infection can trigger endotheliitis, inflammation of the blood vessels. It can trigger a cascade that sets off and activates proteins related to platelet hyperactivation and clotting. And we still do not have great metrics to understand if the clotting and the platelet hyperactivation is happening on a very sort of small scale or local scale. We're still not great at understanding what's occurring and how to measure it. But that's a limitation of our measuring capabilities, not a denial of the fact that it's happening in the body, because we have peer-reviewed literature showing this over and over again. So, it really is something that is a great concern, and we need to start thinking about therapeutics that can address this.
Yeah, well, thanks, Dr. Putrino. I want to bring Dr. Wisnivesky into the conversation. Dr. Wisnivesky, is there an overlap between post-intensive care unit and post-COVID syndromes? Can you help us understand that concept a little bit better, please?
Sure. Good afternoon, everybody. Yeah, for sure. Post-ICU syndrome has been described for a long time and happens in patients that have been in the ICU and include like three main domains: problems in cognitive function, problems in mental health problems, and physical function issues post-ICU. And all these areas has a clear overlap what patients with long COVID experience. In terms of physical symptoms, post-ICU is related to a lot of fatigue, sometimes exertional fatigue. Patients have muscular weakness or joint pains, also common respiratory issues, particularly patients who have ARDS. All these symptoms and cluster of conditions are frequently seen in post-long COVID. In terms of cognitive challenges, we have described already, Julie mentioned her issues with brain fog, and others have commented on that, and that's also very frequent. Up to 30% or more patients that have been discharged from the ICU have those problems. And then all the issues related to mental health, which are, depression, anxiety, and even PTSD are very common among ICU survivors and have been reported in long COVID. All these constellation of conditions and symptoms really both in post-ICU patients and long COVID patients impact, functional status, quality of life, sleep, et cetera, et cetera. Why is this overlap? Well, I think first, although as been pointed out, most patients with long COVID had mild disease at this point. Earlier in the pandemic, long COVID was more common among patients with severe disease that had long hospitalizations or ICU visits, and obviously that's a clear shared risk factor. Also, probably related to the mechanistic reasons for these conditions, both probably involve the inflammatory response to the body to an insult. So that shared pathway leads to these overlapping conditions. And then I think both conditions, particularly early on, were associated with pre-existing diseases, and therefore, that's also a shared common risk factor. However, I think it's important to point out there are differences. First, most long COVID patients right now had mild disease, very different from an ICU course. Some of the mechanisms of long COVID may be related to viral persistence, which is obviously different from the post-ICU syndrome. And also there are some symptoms that are specific to long COVID that are not frequent in the post-ICU setting. So, post-ICU patients have a lot of many times malnutrition, severe deconditioning, muscular atrophy, or some specific syndromes like post-ICU myopathy or post-ICU polyneuropathy are more specific to this setting. And on the other end, some other conditions we see in long COVID like POTS, GI symptoms, smell, taste abnormalities are more common in long COVID. So clearly, two different syndromes in that perspective. But I think this overlap is potentially helpful because we have learned over the years some therapeutic approaches to post-ICU syndrome like rehab or mental health support or support groups. And I think we can use that knowledge and that literature to guide some of the attempts and initiatives to help long COVID patients.
Yeah, thanks, Dr. Wisnivesky. I want to shift our conversation now, talk a little bit about the pathophysiology here. And Dr. Putrino, if I could go to you on this question a little bit, can you talk a little bit to us about some of the proposed pathophysiologic mechanisms for long COVID, particularly viral persistence? If you could take that, Dr. Putrino.
Yeah, absolutely. I think that one of the things that we often think about is, we're always asking ourselves, why do some people fully recover from an acute SARS-CoV-2 infection and whilst other people don't? And, one of the most logical reasons for exploring that, is just that the virus is not going away. And in fact, the bodies are unable to clear the virus, or parts of the virus are persisting in the body and not being cleared over time. And to that end, there has been an enormous amount of literature, and myself and Dr. Peluso were both on a great review paper that was published this year, led by Dr. Amy Prohl from the Polybio Research Foundation, who show, all of the literature that has categorically shown that in the bodies of people with long COVID, there is persistent viral antigen, there is persistent spike protein, and in some cases we are seeing evidence of the virus itself persisting very clearly, very very undeniably in the bodies of folks with long COVID, and that this appears to happen with greater frequency in people with long COVID than it does in healthy controls who seem to make a full recovery from the virus. So we know that the virus can persist. We also know, and this I think is really important, is that in general, when viruses persist in the body, they don't stick around in the bloodstream. The bloodstream's not a really good place for them. So taking blood and trying to find virus persisting in blood is probably not a good path forward. What we actually need to do is be biopsying tissue, because that's where viruses like to hide out. They hide out in nerve tissue, they hide out in gut tissue, they hide out in blood vessels, and so on and so forth. And so as we start to think about, okay, if viral persistence is occurring, we need to also be developing in parallel a whole new generation of tests that can look for the persistent virus, as well as a whole new generation of drugs that will treat persistent virus. Drugs such as Paxlovid, which have been proposed to address viral persistence, probably are not the best drug out there for addressing viral persistence, because in the first place, it doesn't actually eradicate the virus. It just stops the virus from replicating. And in the other case, it does not penetrate tissue very well. So if the virus is hiding out in the tissue, then Paxlovid isn't going to do a good job. So what we're really seeing as the evidence is mounting for viral persistence being at least one major driver of long COVID, we're seeing a need for better diagnostic techniques, as well as a need for rapid drug development to treat persistence.
Yeah, thanks, Dr. Putrino. And Dr. Peluso, I want to bring you into that part of the conversation. Maybe Dr. Putrino brought up a couple issues. One is the viral persistence. I wonder if you could talk about that. But I think, why don't we talk a little bit too about Paxlovid? Like, we know Paxlovid, a short course treatment for long COVID, not acute infection with Paxlovid, did not improve long COVID symptoms, and newer antivirals and longer durations of antivirals seem to be focus for treatment trials. Could you share your thoughts about this? And we'll go with you, Dr. Peluso, on that one, please.
Yeah, so I agree with everything that Dr. Putrino said. I think, at the beginning of the pandemic, people would ask me as an HIV researcher and HIV doctor, what's the difference between HIV and SARS-CoV-2? And I would say that HIV is a virus that persists, and SARS-CoV-2 as a coronavirus should be transient. And I really believed that at the beginning. And so what David discussed is really there's been a preponderance of evidence over the last 4 years that have shown that framework, that sort of black and white framework, is not correct. We see virus persisting in a variety of locations, but especially in tissue. And the important things to know is that it doesn't seem to be true in everyone. So the first thing I want to say is I don't think that this is going to be an explanation for every case of long COVID. But I think that that's okay. It still seems to be happening in somewhere between maybe 20 and 40% of individuals. And that would be a substantial number of people with the condition that we could potentially intervene upon. As David mentioned, when we talk about virus persistence, we don't mean that people are still contagious to other people and are sort of shedding virus out of their nose or anything like that. What we mean is that there are residual pieces of this virus that, may be stimulating an immune response, even if it's not actively replicating, maybe generating proteins that cause an immune response, or in some cases, maybe kind of puttering along, even if it's not in sort of that dramatic, explosive way that happens during acute infection. So there was this hope, based on some of these initial case reports of people benefiting from Paxlovid treatment, that this would be an easy solution, that, we give people a couple weeks of an antiviral and it would stop whatever was happening. And we know from at least one study so far that a couple of weeks of Paxlovid is not going to be the cure for all comers with long COVID.
Yeah, that's it. And I want to just pick up something you said there. You really got me thinking. It's funny, when I was in medical school, that's when HIV was the new disease.
Yeah.
And, you said that about HIV is a persistent virus, but, COVID, we didn't think of that way. But that's really a different way of thinking about it, isn't it? Not everybody, but just a few people that way, right?
Yeah, the mechanism of persistence is totally different, right? HIV integrates into the genome. It's like a totally different thing. But there's actually a pretty robust literature of RNA viruses like SARS-CoV-2 being capable of persisting, either through mechanisms where the virus sort of becomes kind of dormant and isn't really stimulating the immune system clearing it, or in sort of these local microenvironments that are cordoned off by the immune system, and sort of it can't be cleared. So we know that a couple of weeks of an oral antiviral doesn't work. That doesn't mean that we have the right drug. There are many more drugs that need to be tested. There are many antivirals in development beyond just Paxlovid. It could also be that the duration of treatment, a couple of weeks is inadequate. There's actually a cat model of persistent coronavirus that requires months of treatment with antivirals in order to clear the virus. So it's possible that longer durations of treatment will be needed, but unfortunately, we don't yet have adequate safety and toxicology data to support those types of studies in people. And then it's also possible that there are other types of therapeutics that could clear persistent virus. And so what I'm talking about there are things like monoclonal antibodies that may be able to clear infected cells or sort of neutralize coronavirus proteins without requiring that the virus is actively replicating. And so these are all things that I think need to be studied. I don't think that one or two negative studies targeting this mechanism are going to kind of lay it to rest. And I think that this is going to be a major area of ongoing research. But that's really just, one of the many different mechanisms that are being targeted.
I appreciate that. Dr. Peluso, that was great. I want to just bring Dr. Putrino back into the conversation. I want to bring metformin into the room. It's one of the questions we're getting from the audience as well here is just this whole thing about metformin. So what do you think about the role of metformin in acute disease and also in preventing long COVID? Dr. Putrino, what are your thoughts on that, my friend?
I think that metformin and many drugs that boost our metabolic function are indeed they're very interesting drugs to think about, both in prevention and in subsequent treatment of long COVID. And I certainly know that a lot of people have experienced benefit from metformin with long COVID. However, others have not, and I think that it's definitely something that is worth a proper placebo-controlled, randomized controlled trial before we make any clear statements about its utility. But I think metformin is a really great drug to talk about because it really highlights some of the challenges of running a good clinical trial on people with long COVID. When we think about metformin in the lens and the context of longevity medicine, people use it all the time. They seem to do just fine with it. Minimal, it's this sort of safe drug with minimal downside or side effects. That's not the case in people with long COVID. People with long COVID often will report experiencing severe GI symptoms when they try metformin, and often they need to sort of titrate their dose very, very carefully to get to a point where they might be feeling some energetic benefits from it. And so it's an interesting drug. It does seem to have a mechanism of action that could help folks with long COVID in terms of helping them have a little bit more energy and helping their bodies to produce energy a little bit more efficiently and cheaply, as it were. But one of the things that we need to really consider is how difficult it can be to run clinical trials when the folks with long COVID that we're dealing with are so sensitive to new drugs, even drugs that healthy folks can use without, with minimal side effects. So it's a real challenge.
Yeah, thanks, Dr. Putrino. I want to follow up with you in a minute about rapamycin and the research study you're doing at your center. But before we get back to that, Dr. Peluso, I wonder, we did talk a little bit about the pathophysiology of long COVID. I feel like we spent a lot of time on viral persistence, and I think that was great. Were there other mechanisms that we should think about for the pathophysiology of long COVID?
Yeah, for sure. I mean, we spent a lot of time on viral persistence because that's sort of the lowest hanging fruit, right? Like David was describing, and a lot of the early activity has been targeting that potential mechanism. But there are many other potential mechanisms that are being investigated. So these include things that have come up already, like inflammation and immune dysregulation. And I think over the next year, we're going to see more clinical trials, including the one that David's about to talk about, targeting immune dysfunction, which, you know, seems to be sort of another kind of common denominator among many individuals with long COVID. There are other factors too. So there's a lot of interest in the role of the reactivation of other latent viruses, especially things like Epstein-Barr virus. There's 4 or 5 really compelling studies that have shown that some people with long COVID have evidence that they've had recent reactivation of EBV, and it's possible that that can drive inflammation. It's possible that can otherwise drive other mechanisms of long COVID, including things like autoreactivity or autoimmunity, which is being evaluated. And then there are other potential mechanisms of long COVID that we haven't really touched on, that can also contribute, and that includes things like microbial translocation, sort of leakiness of the GI tract, and exposure to bacterial or fungal elements that can cause inflammation, and also changes in the microbiome that can affect how we feel. And we don't really fully understand those things yet. But each of these mechanisms is kind of being investigated in earnest right now. And I think, you know, we'll learn more. We'll also begin to understand how each of these potential mechanisms are interconnected, and understanding the kind of that web of interconnectedness and how these different processes can drive one another will also be really important in figuring out treatments.
Yeah, thanks, Dr. Peluso. Dr. Putrino, we've been hinting on rapamycin and the clinical trial. Let's talk a little bit about that next, if you don't mind. So I've heard your center is studying rapamycin as a potential treatment for long COVID. Why don't you tell us what's going on with that?
Yeah, absolutely. So in late 2023, we were in collaboration with an amazing collaborator of mine, Geetika Iwasaki from Yale University. We published a paper in Nature showing, amongst other things, that we could, using a machine learning algorithm, we could distinguish between people who had long COVID and healthy controls with around 94% accuracy just using blood biomarkers. And as we dug into what the machine learning algorithm was pulling out as features that distinguished people from long COVID, people with long COVID from healthy controls, some of the things that we were identifying were these measures of T cell exhaustion, natural killer cell dysfunction, and other immune dysregulation markers that really indicated to us that people with long COVID had an immune system that seemed to have been fighting things for a long time and was starting to get tired. And as Micheal, mentioned, in addition to that, we started to see, alongside this immune dysregulation, we were seeing reactivation of herpes viruses, EBV, CMV, very present in the long COVID cohort and not so present in folks with who are healthy controls. Now, how does rapamycin fit into this picture? Well, if you were to just Google rapamycin right now, you would actually see it sort of represented as an immunosuppressive drug. It's something that is given to folks after an organ transplant to make sure that they don't get sort of graft versus host disease, and sort of manages their immune system in that way. However, that's rapamycin at high dose. Rapamycin at low dose, and when we're talking about low dose, we're talking about low milligram dose once per week. It actually has quite a different effect. And when we were scouring through the literature, this again is with my collaborator, Amy Prohl, who happens to be the scientific director of our center. We started seeing this amazing literature saying, well, at low dose, rapamycin is really good at addressing T cell exhaustion. It's really good at improving natural killer cell function. It's really good at improving interferon signaling and suppressing reactivated latent viruses. So it seemed to us that based off the back of our Nature paper, where we were showing these very clear differences between the long COVID community and healthy controls, And the actions that we're seeing for low-dose rapamycin, it seemed like a very hopeful drug to try out. As we announced our intention to trial this drug, it has been received with quite a bit of excitement from the long COVID community, because many folks in the long COVID community have tried it to good effect. So that's often really good validation of the idea that we really need a high quality placebo-controlled RCT to confirm some of the things that folks with long COVID are telling us.
Yeah, thanks, Dr. Putrino. Dr. Wisnivesky, I want to bring you back into the conversation with a couple of thoughts here real quick. So I thought maybe you could talk a little bit about some of the treatment options and symptom management you've used in your patients. And Dr. Wisnivesky, you've been awarded an AHRQ grant, Agency for Health Research and Quality, one of the smallest federal agencies, part of Health and Human Services. You have an AHRQ grant for your work with long COVID in underrepresented populations. Could you tell us about some of the unique challenges in those patients? Maybe I can ask you to tackle those two together, Dr. Wisnivesky.
Sure, absolutely. We talk a lot about several symptoms, and I guess the bad news is, unfortunately, as it's been discussed before, there is not a lot of mechanistic proven treatments for long COVID or any of the symptoms. So right now, we're trying to do symptomatic management, many times trying to use tools like rehab to improve the functional status of patients, both for patients like with POS, with patients with fatigue, with patients with post-exertional malaise, as well as cognitive rehab for patients with brain fog. And some of these therapeutics are used based on data extrapolated from other conditions that we know that help patients. Data for long COVID is emerging, and some seem to be positive, but a lot to be learned. And I think, Dr. Putrino and Dr. Peluso mentioned that, there's a lot of clinical trials ongoing. And I wanted to mention as well that the Recover Network, which is a national study to study the long-term effects of long COVID, has clinical trials that are ongoing, some that are finished recruitment, which will give us input in terms of some therapeutics, some that are still enrolling, and there's a big NIH initiative now to do more clinical trials. So, really a lot of we have to offer right now is trying to engage our patients in these clinical trials, both because may offer opportunities to early exposure to some effective therapeutics to patients, as well as because it's important to do these trials and find out what works and what doesn't. Without that information, we would not know how to treat long COVID. I think one positive remark, which I think is important to say, given that we are in the New York Department of Health, and this is about public health, is that something that is being quite well demonstrated as a strategy to decrease the risk of long COVID is vaccination. So this is, I think, super important, very well demonstrated. And we have to remember that reinfections, because most people, particularly I guess in New York State, have had COVID right by now, or probably had COVID, but reinfections have been linked to increased risk of long COVID. So, I say number 1, 2, 3, 4, a strategy to hopefully decrease the population burden of long COVID is vaccination. I think you asked about our AHRQ grant, and I have to mention that Dr. Peluso also has one of these grants, so we are together in this initiative. This is an effort from the federal government to improve access to care and management of long COVID in minoritized populations. We know from the epidemiology of long COVID that unfortunately minoritized groups have been more exposed and have higher burden of long COVID, particularly early on, and therefore this expectation that the rates of long COVID are also be greater too. And again, unfortunately, we know many times that minoritized patients have many barriers to access to care, and particularly for a condition like long COVID, which requires multidisciplinary teams, multiple testing, access to therapies like rehab, cognitive testing, et cetera, which usually have long waiting times and access barrier for patients without a certain type of insurance, that's a major challenge. So HRQ had this initiative. We got this again. I think right now there are 12 federal grants across the country to establish these long COVID care clinics and increase access to minorities patients. Our is located in East Harlem and is trying to improve access for patients in this area as well as South Bronx. It's been running for a couple of months. It's growing and going well. We're learning as we go. And so, colleagues that have patients with long COVID that have challenges getting them to care, we can contact us, it's in the Signer website, and we're more than happy to coordinate care for these patients. Other parts of the grant that I think are equally important is a component of education for physicians and trainees about long COVID, which is some area also there is a lot of need. So many of us are working on those components to ensure that primary care doctors and as specialists know how to manage these patients.
Yeah, thank you, Dr. Wisnivesky. Dr. Azola, I want to bring you right back in the conversation. I know we're running out of time here. But can you tell me a little bit about the physical medicine and rehab guidelines you published on long COVID symptom management?
Yeah, absolutely. So actually, Dr. Putrino is also part of them. But very early on in the pandemic, the Academy of Physical Medicine and Rehabilitation gathered a group of academic centers that were starting these early clinics to see long COVID patients. And we were kind of crowdsourcing not only physiatrists, but also therapists, neurologists, pulmonologists that got together and shared their knowledge. And we created publications on management of different presentations like shortness of breath, cognitive issues, autonomic dysfunction, which is the one that Putrino and I have co-authored. And this publications has a wealth of knowledge in terms of what the initial workup should be. Actually, even the initial assessment of the patient in clinic, really helpful tips that come from the collective knowledge of over 41 long COVID clinics in the nation. So I think it's a great resource for clinicians out there. And I wanted to add, long COVID affects millions, over 20 million people in America. So even though we have a fabulous 12 AHRQ clinics, these patients are going to be seen by every single member of this audience, really. And it's important to get some basic knowledge on assessment, because these patients are being ping-ponged around the system, seeing multiple specialists. Nobody has an answer. A lot of the times, the regular testing is telling them that there's nothing wrong. And we heard that from our patient, Julie. And it is key that we start learning more about the basics of assessment, the basics of symptom management, because we're very excited about what's to come in terms of treatment. But at this time, there are things that we can do. Even getting the patient in the clinic and assessing them with a 10-minute stand test. All it takes is a blood pressure cuff and maybe a nursing helper that could help you do it. But not only checking blood pressure and heart rate, but also documenting physical signs and symptoms. And that can be really helpful in identifying those patients and validating them, right? Because they have been told that nothing is wrong. So also a lot of them present with allergies, for example, exaggerated allergic reactions that they didn't have prior to the virus. And there are simple things like antihistamines that can be prescribed that can be really make a difference in their day-to-day function. So there are things that can be done. We don't have a curative treatment, but we can certainly make the patients' lives better, their quality of life better, and reintegration to their jobs with simple accommodations like remote working or allowing them to have more flexibility so we can keep those patients in the workforce. So there's a big role for all of us providers to be able to assist these patients in rehabilitation.
Yeah, thanks, Dr. Azola. And I'm going to go to Dr. Putrino in just a minute to talk about where people can go get care. But Mike, we're getting close to the top of the hour here, and I know people need to move on with their day. Why don't you put up the slide that shows how people can obtain continuing medical education? But Dr. Putrino, where do people go to get treatment?
Yeah, it's a really challenging question. I mean, I think that most long COVID clinics and most people who work with long COVID clinics, especially those that see insurance rather than taking cash, will share the experience that we have of just being completely overrun and with fairly significant wait lists to boot. But, you know, I really would urge people to, at this stage, I think what we need to say is really try to find, and I'll echo basically what Julie said, which is really try to find people who are knowledgeable about long COVID, not people who are going to sort of refer you to 12 or 13 different specialists just to get a basic workup of your symptoms. If you can, really try to find the people who are expressing familiarity with the symptoms that you're talking about, as opposed to, oh, I've never heard of COVID causing cognitive impairment, which is something I hear every day, you know, in terms of the patients who come and see our clinicians. And so I would urge patients to just do that. You know, if they're getting the sense that this is the first time someone has heard of these symptoms or are not believing that these symptoms can accompany a SARS-CoV-2 infection, dump that clinician fairly quickly and find someone who does express familiarity with your symptoms or has expertise in long COVID. I know that's really tough, but that's the best advice I can offer right now.
And I think that's one of the challenges we have right now. You know, when we do a grand rounds, we're doing continuing medical education. It's not about solving all the problems. It's about learning together. Right now, I think what we see, though, is that we have a lot to learn, right? But we've had a great discussion about the pathophysiology of long COVID. We've had a little bit of discussion about how to prevent it. The vaccine doesn't prevent every case of long COVID, but it's really the best I have right now. We've talked a little bit about some therapeutic options, and we've talked a little bit about, you know, it's going to be hard maybe, but find someone who does multidisciplinary approach to care and someone who's interested and I think really curious about your situation. And I think one of the things I pulled out from Julie in particular was this invisible disability. And one of the things that really was important for her is to be believed. I think that's so critical. My goodness, what a wonderful panel we've had today. Our hour flew by. You can't thank Dr. Putrino, Dr. Wisnivesky, Dr. Lance, Dr. Sood, Dr. Azola, and Dr. Peluso enough. It was just wonderful to have you with us. My friends, thank you so much for joining us as we journey to continue to learn more about long COVID. Maybe we can get together again sometime and see where we gather the future on this, because hopefully there's a lot more we can do and learn together. My friends, thank you for joining us. Fill out the question, get your CME. We would love to have you earn the CME. Thank you so much. That concludes our session for today. Hope everybody has a good rest of your day. Bye-bye, everybody.